Yeah.
How often is your radiation source evaluated for strength? That's question one. And number two, what determines when you might consider ADT? I know in talking to surgeons that they don't particularly like to do surgery after ADT because it often shrinks the prostate. So initial treatment, would you consider ADT prior to starting brachytherapy, for instance? And why? When?
Yeah. Yeah, so I think we replace our source in the remote afterloader, our radium-192 source, like about every 4 to 6 months or something like that. It just has to do with the life of the isotope. So we kind of have a very defined interval when we do it. And in terms of your question about ADT, which for those who aren't familiar with it, maybe most of you are, but it's androgen deprivation therapy, or what we call Lupron is the most common shot that we give. It's a drug that it's basically chemical castration. It interrupts the signal that the brain sends to the testes to produce testosterone. So your testosterone level goes to zero when you're on androgen deprivation therapy. And Jack, we usually reserve that for the highest risk patients. I definitely
high Gleason's.
Yeah, so I would say, so I'm moving away from even in my intermediate risk patients giving androgen deprivation therapy. I mostly give it just for my high-risk patients. So those are patients with a Gleason score of 8 or higher, or with a very high PSA, usually 20 or higher.
Okay.
Yeah, and I'm a little bit liberal about shortening the interval of ADT if I give a brachytherapy implant, because I know that I'm able to escalate the dose higher with a brachytherapy implant than I would be able to with external beam radiation therapy alone. And so rather than giving the standard 2 to 3 year dose of androgen deprivation therapy for a high-risk patient, I might shorten that to 9 months or a year if I have a high-risk patient with a brachytherapy implant, because I know the dose is being escalated.
And he always warned them about the hot flashes and everything coming in.
Oh, it's, most guys do very well with radiation therapy, and they hate androgen deprivation therapy. I mean, it is the worst treatment for most of my patients. I get more complaints about androgen deprivation therapy than I do about radiation or surgery or anything else.
I can relate to that.
Yeah. Yeah, I mean, testosterone's a very potent hormone. It gives us, strength and vigor, sex drive, everything that makes us men. And so, to take that away is pretty hard on anybody.
Makes the wife giggle too.
Yeah, right, yeah. Yeah.
Over there.
Oh,
Dr.
sorry.
Bittner,
Yeah.
how do you know that you've been successful? You've treated the patient. What's your gauge of how well you did?
Yeah, that's a good question. So the PSA is really the best surrogate for how my patients have responded to their treatment.
So you still believe in the PSA test, and you give it to your patient approximately how soon afterwards, and what is the result that you consider an A paper?
Yeah, so I usually check the PSA about 3 months after they've finished their radiation therapy. Many of my patients, understandably, are really anxious to know how the treatment has worked and ask for PSAs during treatment or immediately after.
Right.
The prostate is very inflamed from radiation therapy, so the PSA is mostly sky high. And if we take it too early, it causes a lot of unnecessary anxiety for patients.
They have to have heart trouble.
Right.
Yeah. Okay.
So that's, I usually check it about 3 months after they finish external radiation therapy or brachytherapy, whatever they do. And then we usually check it every 6 months for about 5 years after that.
Okay. What's the result that you expect? Because typically if you take a person's prostate out, they usually go to 0. What's let's say they start at 10, because that's a nice easy number for remember. What is the expectation?
So this is
You've done a good job.
This is a
A+ job.
This is a perfect question.
Okay.
So everybody listen up.
Okay.
It's, yeah, we don't expect the PSA to go to 0 with external beam radiation therapy.
Why not? It's an A paper, right?
That's right.
I'm joking.
Yeah.
I'm joking.
Yeah. No, I understand where you're coming from.
Okay.
And a lot of people think that way. When you undergo surgery, your prostate's been completely removed. You shouldn't produce any PSA unless they left prostate behind or your prostate cancer has gone somewhere else.
Thank you.
With external beam radiation therapy, you will always have a prostate. Your prostate is still there. It's going to feel flat on digital rectal exam. It's going to feel harder, but you have a prostate, and you will always have a prostate, and healthy prostate tissue produces PSA. So PSA is not a cancer-specific marker. It is something that a normal prostate produces, but that can be elevated in the setting of a prostate cancer because the architecture of the prostate has been altered, and there's some leakage of the PSA into the bloodstream. So generally speaking, to answer your question, we want the PSA to go lower than what it was before treatment, and I have some patients that go to an undetectable level. Most don't. But what I'm more interested in actually is what the trajectory of the PSA does. So that's what's a little bit unsatisfying about radiation therapy compared to surgery. If you have your surgery and your PSA goes to 0, your urologist is great, you know, you're doing very well, you're right where we want you. For me, I'm probably not going to be able to answer the question about whether you're cured until we get 5 years out. I mean, you know, to be
So you
completely honest with
continue
you.
to follow up with your patients for 5 years then?
Yeah, yep. I check their PSA every 6 months for 5 years. Now, if you started with a PSA of 20,
Right.
and your PSA drops to 10,
Right.
and it stays at 10 for 5 years, that's great. I would consider you, you know, under great biochemical control. It would be odd that you know your PSA is still that high, but that would be better than you starting with 20, going to an undetectable level, and then me seeing a value of 2, of 4, of 8, of 16. So the velocity, the doubling time, or the trajectory of the PSA seems to be a more important surrogate for whether you're going to die or be cured from prostate cancer than the absolute value of the PSA does. Does that make sense? Or?
It does, it
Okay.
makes total sense.
How long, when you go to see a urologist, I didn't even know there was different kinds. He talked about a medical urologist and whatever it is you do.
No.
So how much time would you expect to be in front of this fellow when you go to, you know, to have an appointment?
Do you mean on a daily basis for
No,
treatment?
I haven't been to one yet, so the only ones I have been, I ran out of the office.
And so you're talking about an initial consultation?
Yeah,
where you
yeah,
first
so
have
to
meet-
learn what the options and all that are.
Yeah, so when I meet a patient, I usually reserve about an hour the first time that I'm meeting them. So sometimes it goes a little bit longer than that. Sometimes the patient has already, you know, decided what they want to do and have read a lot, and I don't spend that much, but I reserve an hour with a new patient to go through the options and answer questions.
And at that time, are you able to discuss the various kinds of treatments that there are? Or do you kind of stick with the modality that you work with?
Well, since I'm a radiation oncologist, you know, most of my discussion is focused on radiation treatment modalities. Most of the time, in fact, almost all the time, the patient is referred to me by a urologist, so they've already had the opportunity to talk about surgery with the urologist. And the purpose of their appointment with me is either, you know, this patient wants to explore all available treatment modalities and they want to see what you have to offer, or I don't think this patient is a good surgical candidate, can you talk with them about radiation options? And that may be the case, you know, in the 80-year-old patient that has congestive heart failure and renal disease, and they're felt to be at high risk to go under anesthesia for a surgical procedure. Does that answer your question?
Kind of, yeah. Yeah, I guess it does. You're a radiation urologist? Is that how you describe
A
yourself?
radiation oncologist.
Oncologist.
So I actually treat all types of cancer with radiation therapy. I specialize in radiation therapy, not just prostate cancer. Prostate cancer is a very common form of cancer. It's the most common male cancer in the United States. So I see a lot of prostate cancer, but I treat malignant brain tumors, I treat breast cancer, colorectal cancer, lung cancer, pancreatic cancer, everything where radiation is indicated.
I see.
Would one start with a urologist first and then come see you, or just come directly to you?
Most of the time, just by virtue of the way the system works, you're going to see a urologist first because a urologist would be the one that does the biopsy. So usually what happens is either, you know, one of you guys presents to your primary care doctor and has an elevated PSA, or if they don't do PSA screening, you say, hey, my urination has changed a little bit, or they did a digital rectal exam on you and you had a palpable nodule. And then the primary doctor refers to a urologist. The urologist says, hey, they need a biopsy. They get a biopsy. And then the urologist will diagnose your prostate cancer. If they're a good urologist, they will make sure that you know what all your treatment options are and not try to indoctrinate you into surgery. I think everybody deserves to know all the treatment options that are available to them. But most of the time, you're going to see a urologist first. And most of them are very, very good in this community, and we'll make sure that you know all your options.
I have a question. What about a .01 PSA after 12 years?
That's pretty dang good. Yeah.
Glad to hear that.
Yeah.
Shouldn't affect your golf. Yeah, that's a problem, but it's gonna get your swing taken care of.
Yeah, I'd be happy with that.
Good.
Yeah.
I'm glad to hear that.
Yep.
Yeah, very good.
Who is not a good candidate for brachytherapy?
So that's also a very good question. So what I usually have patients fill out before I meet them is an IPSS score or an AUA score, and it's basically a questionnaire that talks about how much you get up at night, how often, how weak your stream is, whether you have intermittent flow, whether you feel like you completely empty your bladder, and so on. In patients that have a pretty high IPSS or AUA score, we may be a little bit hesitant about implanting them because, as I mentioned, earlier on, this tends to be a little bit rough on your urinary function, especially in the short term. And those patients who have poor urinary function at baseline are not going to be very happy with me, when I put needles into their prostate, because it's going to get inflamed and magnify all the symptoms that they already have.
Oh.
The other patient that I tend to be a little bit hesitant about implanting is someone who has a very large prostate gland. So a gland of 50 cc's or lower is probably okay to implant, but you have some guys that have benign prostatic hypertrophy, just an enlarged prostate that's 70 or 100 cc's. They also are more likely to obstruct, and so we have a little bit of hesitation about implanting them as well. Patients that may be on blood thinners, it's not insurmountable, but this is a procedure where we have to insert, like I said, 20 to 25 needles into the prostate. So if they can't go off Coumadin, for instance, or Plavix, that might be a contraindication to doing the procedure. So those are kind of the things that I think about.
I got an odd question.
Yeah.
You got cancer, you use brachytherapy or external beam. After you get the cancer gone, can you still produce sperm?
With brachytherapy, yes. So there's two things. Do you produce semen or do you produce sperm? In order to stop producing sperm, we would have to actually give a significant radiation dose to the testes themselves, which most of the time we don't with either external beam radiation therapy or with brachytherapy. So we usually don't affect the sperm count. In some patients, particularly the high-risk prostate cancer patients, we treat a portion of the seminal vesicles, which are kind of these they look like Mickey Mouse ears on top of the prostate, but they basically produce the ejaculate. And if I give a high dose to the seminal vesicles, either with brachytherapy or external beam radiation therapy, patients can describe what I refer to as a dry orgasm. In other words, they can reach climax, but they don't produce any ejaculate. But it's not that they're not producing sperm, it's that they're not producing semen.
What's the difference?
So the same effect. I mean, you're not able to reproduce if you're not able to get the sperm delivered, so to speak.
Mm-hmm.
You basically have the same result. Right?
It could have that effect, yeah. Yeah, if you had a high enough dose to the seminal vesicles.
I know for recurring cancer and once in a while salvage prostatectomy is called for, and it's hard to do because of what the radiation does. Is brachytherapy and the same kind of effect on the prostate as external beams in that respect?
That's a good question. So Probably less so. The reason being is because external beam radiation therapy is going through many planes of tissue on its entrance into the prostate, and so there's more collateral exposure of tissue with external beam radiation therapy. With brachytherapy, the dose gradient is very tight, so most of the dose is going to the prostate itself. So I have to admit that, I have not ever sent a brachytherapy patient for a salvage prostatectomy, but if I ever had to, I would imagine that it probably is easier to operate on a patient who is post-brachytherapy than someone following external beam radiation therapy, just because the dose exposure to adjacent tissues is lower with a brachytherapy implant. We don't usually see local failures with brachytherapy, and it can happen, but it's relatively rare because we're escalating the dose so high in the prostate that it's sterilizing a lot of cancer in the gland. The more common form of recurrence when patients fail brachytherapy is that the disease has gone somewhere else.
As salvage therapy, do you rule out HIFU and cryo, for instance? You just mentioned it's tough
Yeah.
for a surgeon to get in there and do something after radiation. I think most of the people I've talked to said, but I haven't asked them specifically about, well, what is next then?
Yeah.
Could cryo, could HIFU be considered?
Yeah, so you're talking about a failure after radiation or
Yes.
failure after surgery?
After radiation.
After radiation. So I don't have a lot of experience with HIFU, I'll admit that, and it's not something that's widely acceptable. Steve, just to the left of you had asked about that, and that may be something that we collect more data on and can use as salvage. Cryo is used very common for salvage after brachytherapy. In fact, that's probably where I send patients most if they fail after a brachytherapy implant. It's not for a prostatectomy, but for cryo. And Peter Grimm, who unfortunately, he was a pioneer in the field of prostate brachytherapy and just in prostate cancer treatment in general, just passed away over the course of the past 12 months. But he was a world-renowned brachytherapist that worked over in Seattle. And he was actually developing a cryotherapy program with one of his colleagues as well. And I had talked to them before he passed away, and they were having quite a bit of success with it as a salvage treatment.
He spoke to us about 6 months before he passed on. True pioneer.
Yeah, amazing
Very
guy.
experienced.
Yeah.
He was part of the gentleman's group that did my brachytherapy walk on rock. That was years and years ago, obviously. It seems like it's a tough thing to evaluate when you don't have a specific PSA that you say, well, if it goes above that, it failed. When Roger did mine, for instance, he was doing a lot of clinical lab work, and he accepted a 0.5 PSA as being a success. Anything below that, he said, well, I didn't really succeed. I've got people out there playing golf and tennis and everything, and they're live and happy, but I didn't really succeed because I didn't achieve this 0.5 PSA.
Yeah.
So nowadays, that you have so many variables and looking at it, it seems even more complex to judge whether or not it was successful.
It does. Yeah, you're right. So, there have been people that have looked at this. For radiation therapy, what is the best definition of biochemical failure or success? And as you alluded to, historically there were some who used a threshold definition. It sounds like your physician said, hey, I feel like I failed if I don't get the PSA below 0.5. Threshold definitions turn out to not be a very reliable predictor of success with radiation therapy. There's also some who used a definition where you say, hey, if I see 3 consecutive rises, I'm going to score that as a failure. That turns out not to be a great way of looking at this either. At least with external beam radiation therapy, the best predictor of how you're going to do if you're going to be cured of your prostate cancer is this definition that they call the Phoenix definition, or nadir plus 2, which is the lowest value of your PSA after completing your radiation therapy plus 2. If you go above that threshold of the definitions that we have available, that's the best predictor of whether you're going to die of your prostate cancer if you go 2 above your nadir, or your lowest value.
So generally your peer group accepts that as
Yeah.
Okay.
That's what most people use now is that definition of NADER plus 2. Now, I wrote one of my former colleagues and I during residency, we wrote a textbook chapter about definitions of failure and how do we know if people are dying of prostate cancer or going to die of their prostate cancer, because patients want to know this stuff. And it turns out, and this gets back to what we talked about, which is the rate of rise of your PSA is the best predictor of whether you're going to die of your prostate cancer. PSAs that are rising rapidly are not good. And there are some patients, and I have a handful of them that I watch right now, that I know technically that they are failing their treatment because their PSA rises every time I see them. But the rate of rise of their PSA is so slow that they're going to outlive their prostate cancer. So, we really do look at things like doubling time and velocity, and we call them sometimes clinically insignificant prostate cancers. I can sit down with the guy and say, hey, you have failed biochemically, but don't worry about it. Continue to play golf, continue to hunt, continue to fish, do what you like to do, because it's very unlikely that this is going to get you. Something else is going to get you before it does, because your PSA is rising so slowly that it's a clinically insignificant prostate cancer.
Yeah, I want to follow up on his question if I can. That could well be the case, but the number of plugs that you have, of course, the percentage in each plug, but that's because of the success of that needle hitting that spot, as you profoundly know. So it's possible that you can have a lot more cancer that's not detected, but you're showing a slow increase in growth. Where does that leave you as a guide and the patient? I mean, it's like, or even where the 20 or 30 plugs shows nothing. So I mean, I'm trying to understand really the tools you're using the MRI, okay, you're using plugs and years of experience, but how definitive is that for us to make the choice, which is the patient, on which is a better approach to their cancer?
Yeah. So the most reliable predictors of what risk group that you fall
Yes.
into at initial diagnosis are still probably your Gleason score and your PSA.
And the PSA is under assault.
Yeah, the PSA is under assault as a screening mechanism. It's not under assault in a patient who has a prostate cancer diagnosis. So the issue with people criticizing PSA screening is that it was resulting in an unnecessary number of biopsies and an unnecessarily high diagnosis of low-risk patients who may have never had clinically significant prostate cancer. So the criticism of PSA is that it has resulted in the overtreatment of prostate cancer. But in a patient who has a biopsy-confirmed prostate cancer, there's no doubt or debate among anyone that it is a very valuable tool of the status of your disease.
I think your word, Doc, there was a presenter on Portland 2 months ago that was talking about some recent issue about the PSA, whether it's a good tool. I just wonder if you're aware of any controversy right now about the PSA, for those that have been diagnosed with cancer.
Yeah, not for those that have been diagnosed. There are other biochemical markers, that you can look at. Alk-Phos, you referred to volume of disease and the percentage of positive biopsy cores, and in patients, that have greater than 50% core positivity, that seems to be a surrogate for more aggressive disease. But PSA is the best tool that we have to monitor your prostate cancer.
What I'm learning, and I'm from Portland, so I take this time with you as a gift. But what I'm learning is that I've got a urologist that hangs his hat on the fact that if you don't have to do anything at all. But I can get a call from a surgeon cohort that'll say, you should consider surgery at this time. And unless I come to groups like this and I listen to what you have to say and I take the experience of those that are here and throw it all in the pot and decide for myself, it's very easy to listen to a professional say, it's time. And you're looking at a beam implant that I know of somebody that has high success with. Yet there are other gentler approaches, or those have had. We had a man here 2 months ago that said he had surgery at UW, I believe, and he's had no complications at all. He's probably in his 30s, and he looked at the big picture and decided surgery was the best for him. It's very hard to listen to the experts and decide for ourselves, because each expert is saying that I believe in what I'm saying to you.
Yeah,
So you don't have to oversell yourself.
yeah.
But were you in our predicament, and you have to make a choice, what would you like to do?
Yeah. Well, it's a difficult question to answer because there's so much that goes into making that decision. If I were 50 years old with, a high-risk prostate cancer, or, I'm 40, I'll be 44 in August, so say I have prostate cancer at 44 years of age, I probably would undergo a prostatectomy because, there's a pretty good body of data that suggests that, hey, younger men with higher risk prostate cancers probably will do a little bit better with a prostatectomy. You're not exposing yourself to a radiation dose, which could cause secondary malignancy 20 to 30 years down the road. My time horizon's a little bit different, so I'd probably do prostatectomy. If I were a 60-year-old guy with a high-risk prostate cancer and really good baseline urinary function, I'd probably do a combination of external beam radiation therapy and a brachytherapy implant because I really believe in that modality for the high-risk population in the age group that generally develops prostate cancer. If I was a 70-year-old guy with one core positive with Gleason 6 cancer and a PSA of 5, I'd do nothing at all. I'd check my PSA periodically and go through a surveillance program and maybe undergo biopsies every couple of years. I wouldn't subject myself to the morbidity of the treatment because, that cancer may not ever cause me any problems. So what I would choose to do, I'm not an evangelist for radiation therapy. It's not a one-size-fits-all for every patient. Some patients are going to do a lot better with radiation therapy because of their goals and the characteristics of their disease. Some patients are going to do better with surgery. Some patients with unconventional approaches. Some patients are going to be quite content to just go on hormonal therapy and call it good. And so, it really depends on the goals of the patient, what's most important to them. If your continence level is the most important thing to you in the whole wide world, then surgery is probably not a great way to go. But if you have ulcerative colitis or Crohn's disease, external radiation therapy is probably not a great way to go because we're going to expose your rectum to radiation dose, and that can aggravate inflammatory bowel disease. So there really is not a one-size-fits-all. You really have to tailor it to the patient. And that's why it's important to get the opinions of others. This is probably the best resource that you have because you can talk to guys who've seen different urologists and radiation oncologists, and I'm sure some guys have great success stories and some guys, quite frankly, think their physician sucks.